Once again, welcome to all of you, and this is the second part of the bacteriophages after introduction of the bacteriophage basics. And you know that we just tried to have the uh, test the efficacy of these bacteriophages locally in the healing of chronic wounds. The reason being that the ethical committee permits the use of these bacteriophages locally, and still the permission is not there by the DCGI to use it parenterally. So no intramuscular, no IV, nothing can be done. So that's why we have taken this one just to see what is happening. And you can see the chronic wound is defined as that does not heal in an orderly set of stages and in a predictable amount of time, or wound that do not heal within 3 months are often considered as chronic wound. Chronic wounds often remain in the inflammatory stage for too long and may never heal or may take years. So what are the different etiology? There are so many. You can see the metabolic disease such as diabetes mellitus, systemic disease such as rheumatoid rheumatic disease, other forms like chronic disease such as HIV infection where the immunity has gone down, old age, malnutrition, poor diet, alcoholism, narcotic abuse, medicines such as steroid, estrogen, vitamin K antagonists, and smoking. So these are so many factors which are systemic causes of the this chronicity of the disease. But the main thing is that the majority of the infections, according to a Chinese study, that 67% of the ulceration in trauma center or traumatic wound are compounded by infection, which is further complicated by biofilm formation. So infection followed by biofilm formation is the most important thing. And the very important thing is that the biofilms are resistant form of the bacterial stages where the antibiotics are basically helpless. Even if the sensitivity is there, they cannot do much help to the patients. So what is this biofilm? You can see the amalgamation of so many types of bacteria. You can see the different colors, different shapes, and this one, and they are enjoying like demons, and they are staying there in a multicellular form to protect themselves from the outside enemies. And you know, our body is basically a biofilm evolved out of the biofilm formation. So we should not curse. This is the survival strategy, and we have got so many number of the cells in our body, that is 10 power 13 human cells. That is basically because of the biofilm formation. And then our body is also colonized by more 10 times more bacteria and even 10 times more viruses, that is 10 power 14 and 15 in the body. So our body is basically, body cells are living in the sea of the microbes, and the viruses are 100 times more and bacteria are 10 times more. So you can just appreciate the importance of biofilm. So you can see the biofilm slow penetration is there. Resistant phenotypes may evolve because of the chronicity of the infection, and the environment is altered. So this may lead to the less or poor activity of the antibiotics. So this is the reason why a thick layer formation, poor penetration, resistant phenotypes development, and altered environment leads to the chronicity of the infection, and the conventional antibiotics are unable to cure them. So I shall be giving you two examples, real cases which it did long ago, and then the study we have conducted, the randomized control trial, that I shall be showing you in this presentation within 20 minutes. And then you see this, this is the 66-year-old male, diabetic for more than 15 years and suffering from chronic wound for last 6 years. He has undergone several rounds of conventional debridement, local antiseptics, local and systemic antibiotics, but without any fruitful result. You know, the debridement and the local antibiotics are very important, are key for the treatment of the chronic ulcers, chronic wounds. But despite this, he suffered amputation of the two toes, as well as he was telling that he has spent more than 4 lakhs, but without any avail. So you can see this is the initial situation on this date, May 2019. And then there was a big hole on the plantar aspect of the wound, and this is another wound there. And you can see that we isolated the bacteria from here, that was Staph aureus. And then we prepared the different phages, more than 3 phages. And then we had a cocktail of 3 different phages so that the chances of the mutant resistant development can be taken care of. So we start simply soaking in the gauze piece. We are giving every alternate day during the overnight, means overnight that gauze piece was put over the wound surface, and we are not giving any antibiotic, either local or systemic. And you can just see the effect every week interval. The photograph have been taken, and you can see how it is healing. This is now 22nd May. You can see something has happened. The wound depth has been reduced. And then again you can see another week later, means it is almost 1 month has passed, and we have reached to this place, here also, here also. And here you can see almost gone that the deep wound. And then this is June 13th, almost 1.5 months. Then you can see this is say 2 months, almost no wound is there. And then this is exactly 2 months later, there is no wound. So in 2 months it healed, but we followed this patient to see that if there is any recurrence. So you can see we have followed, this is 8th July, 16th July, and 22nd July, 30th July, and in August also there is complete healing. So you can see that this therapy led to the healing of this, which was not healing for last 6 years. The another case is a younger brother of one of the plastic surgeon. He did the skin grafting for 2 times, but and he did whatever can be done with the conventional therapy, but with failure. So he was suffering the chronic ulcer for 2.5 2.5 years, and he was diabetic. So you can see this is December 12, 2018, and serial pictures you can see like this: January 10, January 20th, January 24, January 25th, January 28, 29, March 8, and March 16 there is complete healing. So, and this has not recurred. He is very well known to me because that plastic surgeon was 2 years senior to me, a friend of ours. So we are knowing this. So what is bacteriophage therapy? The respective phases were applied every alternate day over the surface and covered overnight with sterile gauze till the wound became sterile. So usually 7 to 8 applications are sufficient, and then we follow that the surface remains sterile. If any other bacteria comes, then we isolate the another phages for that bacteria. The bacteria is different, and then we give the therapy. But usually if it is once cured and the wound is kept in a proper way, so there is no another infection. So in this study, we took a total of 45 cases, and out of them 37 cured. The cure rate was 82.2%. The 6 cases which we missed, there were so many reasons. One was the vascular region. One patient undergone amputation without informing us. One patient was lost. So there were many things. And one person was a chronic alcoholic and not following the maintaining the proper hygiene. So after one bacteria, another bacteria was infecting that wound. So that's why it failed. A police constable. And you can see the duration of healing and status of diabetes mellitus. So non-diabetic patients were 19 and the diabetic patients were 26. So you can see in non-diabetic, this healing started 21.1% of the cases healed by 21 days, but there was no healing in diabetic patients. But after 2 months, 10.5% of the patients, almost 31% of the patients were cured by 2 months, while only one case at the end of 2 months, this was 3.8% diabetic could heal. But by 3 months, means 90 days, 63.2% of them healed and the 69.2. So there was delay in healing with the diabetes mellitus patient, but their healing was good, and this success rate was uh, insignificant if compared in the both groups. So you can see there are so many bacteria infecting the wound. Escherichia coli in 8 cases, Pseudomonas 9 cases, Staph aureus 13 cases, Klebsiella 4 cases, and mixed in 13 cases. And you can see the most resilient and most resistant bacteria, and the time which took longer, it was the Klebsiella pneumoniae. Others healed faster. So after 90 days even, the healing was not complete, or the wound size remained larger. So there was no much change in the blood parameters, but the hemoglobin raised from 10.44 to 11.25%, and it was significant. And otherwise, the lymphocyte count, which increased, and the other total leukocyte count came down. And then if you just see the size and depth, the edge undermining, necrotic tissue type, necrotic tissue amount. So everything day 1 versus day 21, you can see it was significantly reduced. And if you compare day 1 to 3 months, 90 days, again you can find the significant difference, excepting this undermining. It was already covered, so there was not much difference in this, the undermining of the wound. So exudate amount and the surrounding skin color, peripheral tissue edema, peripheral tissue induration, granulation tissue epithelialization, everything, you can see there was significant difference between day 1 versus day 21. And same was day 1 versus after 3 months there was significant improvement. And I'm showing you a few of the cases. You can see this is a female non-diabetic having the wound. You can see the site, and then you can see this is the slough, pus material, dead debris is there. Before the starting of the treatment, we isolated the bacteria, I started the therapy, and this pictures comes on day 21. This is healthy granulation tissue. You cannot see this infected debris material here. Sloughing tissue, this is quite cured, and the margins have started healing here, and by the day 75 you can see this, only this much of the wound has been left. This is another case. You can see starting from day 1 to day 90 complete healing is there. So all these cases were as I've given in the definition, they are coming after the 3 months of conventional therapy failure. And this is a 55-year male diabetic, and you can see the big toe has been amputated, but the healing was not occurring with the conventional therapy. Then he came to us, and then we started therapy. Again, you can see the healing process has started significantly by the end of 21 days, and here is complete healing. Again, this wound you can see 30 years non-diabetic male. Here again you can see this, there is a complete healing by day 90. A diabetic male, you can see this plantar aspect is really very tough to get it healed because all the time mechanical injury is occurring there. But even in this case, we are having the complete healing. This is diabetic male, and you can see very bad wound is there. And we started the therapy, and later we came down to this by the day 60. And then this is another case, a very deep wound, 45-year diabetic female. This is, you can see the infected slough tissue, yellow material is there, and we started the therapy. And again, you can see here, this is again a plantar aspect of the foot. And here you can see the healthy granulation tissue, no sloughing, no debris, the tissue which is very clear, bright red, and it means the healing has started. Day 60 is this picture, and day 90 complete healing. In this case also, again you can see it's a diabetic male, and by the end of 90 days there was healing. So bacteriophages have a number of properties that make biofilm susceptible to their action. Why the antibiotics were failing, I have just shown in that picture. But here you can see they are known to produce, are able to induce enzymes that degrade the extracellular matrix which is present in the biofilm, because the biofilm is formed by the live bacteria. There are certain viruses and the extracellular matrix excreted by the bacteria. They are also able to infect persister cells, means they are not actively multiplying, but they are infecting them, remain dormant within them, but reactivating when they become metabolically active. So this is the beauty with this. While antibiotics over the period of time, they are getting degraded in vivo and they become ineffective. While in this case, if the bacteria is not multiplying, they will also remain sleeping with the bacteria. When it becomes active, they become active. Some cultured biofilm also seem better able to support the replication of bacteriophages than comparable planktonic system. So it is said that the biofilms are basically helping the replication of the bacteriophages. It is perhaps unsurprising that bacteriophages, as the natural predator of bacteria, have ability to target this common form of the bacterial life, because the biofilms are naturally found in the in the nature, and the bacteriophages are the natural products, so they are basically trained for dealing with the biofilm formation, because degradation of the bacteria is essentially needed for the maintenance of food chain. So this is not unusual, and we are simply exploiting the natural process, nothing special. And you can see the attack by the bacteriophages. Integrity of biofilm disrupted by destruction of cell producing the biofilm matrix. Progeny bacteriophages diffuse through the biofilm. Biofilm matrix attacked by the enzymes produced by bacteriophages on their bacterial hosts. So these three mechanisms are there. Persister cells infected by bacteriophages which remain dormant until they reactivate, then lyse them. So with this I have explained you earlier. So we published recently two papers. This paper was published on the basis of first customized this trial, clinical trial. A prospective study was there in 2019. Until date, we have got 43 citations, and we are hoping that within 5 6 months it should cross 50, because I have to reach the at least my H factor 49. If this paper goes to 49, six more, I shall be getting this one. Then this another paper, the data which I showed you, the many of the cases are from this paper, and this has been published in December 2021, and by this time there are 27 citations, and not in a very great journal. This is the medium size journal having the impact factor 2.5 or something like this, and in this case we have uh, got the success, and they are highly cited papers. So these two papers have citation we have got within maybe in 1.5 years, more than 60 citations. So conclusion is that the topical bacteriophage application is effective therapy for the treatment of non-healing wounds irrespective of the drug resistance status of the infecting bacteria. So bacteriophages don't consider whether the bacteria is resistant to antibiotics or not, because their mode of action is different. They are basically going inside, attaching on the cell surface receptors like viruses, multiplying inside, and then lysing the bacteria. It seems that the bacterial infection associated with biofilm formation may be the major issue in non-healing of the chronic wounds, as 90% of them healed with the bacteriophage therapy. There was neither serious adverse effect nor adverse effect when we underwent this bacteriophage therapy in number of patients. So this is the second part of the lecture, and here I would like to tell you that bacteriophages are being used at that number of places, and we are is having the uh, double blind randomized control trial going on, where we are going to have the 47 cases in each group. This I've given as a PhD topic, and we will be looking that is there any immunological response coming in those patients, like antibody formation against the bacteriophages, because bacteriophages can neutralize them if they are used for longer duration. Usually we have not found the rabbit model. I shall be showing you in the coming lectures. But in patients, we wanted to see in detail about the this serious adverse reaction and adverse reaction, if it is there any, and then also the failure. Failure may occur basically because of the vascular disorders like the varicose vein, where the edema is occurring. Our patient is having serious immunocompromised state or the nutritional deficiency. In those cases, we may get the failure, but this is the hope. The only thing is that the bacteriophages are like smart bomb. They will be, it's better to have the customized bacteriophages. However, in these chronic cases, it takes about 6 days to prepare a customized bacteriophage, from the isolation of the bacteriophages till the purification, making them endotoxin or toxin free, so that patients are not having this adverse effect. So this takes only this much of the time. So I think this is boon to us for to cure these such type of cases. And I'm getting the request from the whole country for the treatment of these chronic ulcers. So thank you very much. And again, in the second part of this talk, and it was better that I was there and I was able to answer the queries which were coming in your mind. So again, thank you very much.